Mr. Chair.
Good afternoon, Senator. Welcome. We're in item number, hold on, let me make sure we're.
Yeah.
Item number 9, SB 346, healthcare facility benefits. Is that correct?
Yes. Yes, it is.
Thank you.
You know, Senator, I woke up shortly after 4 a.m. this morning worried about my presentation today because, you know, the committee report's thorough, and it starts on page 15. You read this whole list of oppositions and people that are opposed to this, and this is my third time on a charity care bill. And, you know, when I first did the bill and I was going to take away nonprofit status, every saint, St. James, St. Ed, St. Louis, St. Isidore, St. Richard, St. Holly, they were all against me. Every hospital with a saint. And, you know, I've got, you know, we've got an opposition letter from a nonprofit local one that is bringing an end to domestic violence and sexual assault in partnerships with our communities. And these are not the people that I want to have opposed. They're saying that, you know, this is going to impact our existing partnerships. We have existing partnerships. What are you doing, Senator Wachowski? Why are you bringing this bill forward? And one of our sponsors, the California Nurses Association, they have a report. It's a research arm, the Institute for Health and Social Economic Policy. And they did some research on this. And I freely admit, they said it looks as though the nonprofit sector is underreporting or undershowing the benefit to the community by $1.8 billion. That jumped out at us. That jumped out at me, and they're saying two of the big nonprofits, one of them which I'm a member of, I could pull out my card, is maybe short $1 billion. And in the old days, when the federal government would require 5% of your aggregate revenues to go towards charity care and nonprofit, that seemed to be a good wage. It looks as though this institute's saying, look, we're less than 2.5%. So the legislation that we have before us today, SB 345, will create a standard definition of charity care and update the community benefits requirements for nonprofit hospitals and nonprofit multi-specialty clinics. This is a result of not one, but two accounting or state audit reports that said, do something, legislatures. We want you, the legislators, to come up with something. This bill would also boost community involvement and transparency by requiring California nonprofit hospitals to meet public accountability standards on how charity care and community benefit services are provided to the underserved and the vulnerable community. As I said, the problem is that in exchange for providing these various community benefits, such as charity care and improving community health care, the California's private nonprofit hospitals are eligible for a variety of tax exemptions because of this nonprofit status. However, the charity care and community benefits are not uniformly defined or measured, which prevents our communities that we represent from determining whether these hospitals that we all love and we all attend are sufficiently contributing to the community, and a duty that nonprofits are required to fulfill under state and federal law. Studies have shown, as I said, that we're not getting a fair return on our investment. So to address this, included in the report, in the staff report, are recent amendments which include the following. Under the definition of community benefits, nonprofit hospitals and multi-specialty clinics will be able to report and count the shortfalls in Medi-Cal, California's Children's Service Program, or county programs at cost of up to 125% of the Medi-Cal rate. Hospitals will be allowed to report these shortfalls in Medicare, but not count them as community benefits. Second, we're going to replace the term available community benefit monies with total economic value of community benefits to ensure, again, we're the legislators, this is the Senate, we're going to ensure that the economic benefit allocated towards improving community health to underserved and vulnerable populations is maximized. Third change is to allow private nonprofit hospitals to count the repayment of employee student education loans. We're going to say that's a community benefit, and as long as those are for people who are working amongst our vulnerable population or are counted as vulnerable populations. We're going to redefine the definition of community benefits as a list to provide clarity in interpretation, to serve the underserved and vulnerable populations, or to address a specific need identified in the community health needs assessment. Fifth, the definition of vulnerable and underserved population is broadened. There's an opposition that was put in. We're going to include individuals who are underinsured or uninsured, include a population who faces exposure to financial and medical risk by defining low and moderate income individuals of up to 400% of the federal poverty level, unless the hospital for which it serves and the local ordinance in the area even makes it greater. We're going to include on these vulnerable and underserved populations individuals with limited English proficiency. And we're going to expand it to a population that meets the definition of disadvantaged community under the health code section. Lastly, hospitals will report their community benefits plans to OSHPD and the community needs assessments every 3 years, which is every year annually for the benefit plans, and the community assessment every 3 years, which is consistent. That was another objection. I've tried to address the objections that were raised and outlined in the report. I'd like to thank the chair and the committee for their work and for the indulgence of all the members on the committee. And I have some people who are here to testify in support.
Thank you. We are limited to proponents for 6 minutes. Opponents 6 minutes. Please proceed. State your name.
Mr. Chair, members, Deanna Johnson on behalf of the California Nurses Association. I'd like to thank your staff as well for the great work that he did on our analysis, and I would like to give the remainder of my time to our board member, Kathy Donahue.
Hi, good afternoon, and members. My name again is Kathy Donahue. I'm a bedside RN and a member of the California Nurses Association, as well as elected member to their board of directors. Currently, nonprofit hospitals must provide charity care and community benefits in exchange for their nonprofit tax status. Unfortunately, there is no definition of charity care in the law, and community benefit requirements are vague at best. SB 346 is designed to end the questionable characterization of certain expenditures as charity care and community benefits, as well as allow community members to participate in the community benefits planning process. A 2012 CNA study documented that California's nonprofit hospitals collected $1.8 billion in tax benefits beyond what they provide in charity care, and that states 100 largest hospitals pay their executives annually over $1 million apiece. St. Joseph Health System, Providence Health System, Adventist Health, and Scripps Health all purportedly provided charity care in an amount that was less than half the equivalent amount of their net income, which is their profits, right? Kaiser Permanente, Sutter Health, Memorial Care, and Cottage Health all provided charity care in an amount less than a quarter the equivalent amount of their profits. In March, Sutter reported that it spent only $91 million in charity care in 2014, down from $166 million in 2013 as their profits increased. Sutter's spending on community benefits plummeted from $901 million in 2013 to only $767 million last year. And Sutter is currently pushing to close an Oakland residential rehab facility, Thunder Road, for teenagers in need of substance abuse or mental health services, an operation it presumably counts as part of its community benefit contribution. And yet in the past 5 years, Sutter has recorded $3.5 billion in profits, or as they call it, excess revenue. St. Joseph Health System, one of the largest Catholic California hospitals in California, ranks last in the provision of charity care as a percentage of operating base, according to OSHPD. While hospitals continue to reduce services or close units, Kaiser's long-term investment portfolio value doubled between 2009 and 2013 from $11.4 billion to $22.9 billion. Sutter Health's investment portfolio also nearly doubled from $2.6 billion to $4.8 billion in the same period. These wealthy nonprofits should support the communities they serve in a more meaningful way. SB 346 has been amended to allow hospitals to count the shortfall between Medi-Cal and some government programs up to the actual cost not to exceed 125% of the Medicare rate as a community benefit. Amendments have also been accepted to further clarify vulnerable populations and allow for hospitals to identify specific needs within their communities through the Community Needs Assessment and Planning process. All this bill seeks is to standardize definitions, increase transparency, and allow community participation in the community benefits planning process. We think adding more transparency in exchange for over $1 billion in tax-exempt status by the people of California is fair and reasonable, and we respectfully request an aye vote.
Welcome. Who else would like to speak in support?
Good afternoon, Chair and members of the Senate Health Committee. My name is Anthony Galassi, and I'm the Health Policy Fellow at the Greenlining Institute, a statewide policy organization committed to achieving racial and economic justice. We proudly co-sponsor SB 346 because this bill is built on three main pillars: increasing transparency, improving accountability, and maximizing community engagement. Two Greenlining studies in 2013 and 2014 found a disturbing lack of transparency in the reporting of hospital systems across the state. For example, in 2010 alone, nonprofit hospitals gained almost $3.3 billion in tax benefits. However, only $1.4 billion were spent on community benefit. Furthermore, unclear guidelines for community benefit and charity care permitted these hospitals to excessively claim tax benefits, and the state had little authority to hold them accountable. SB 346 represents a very unique opportunity to address these issues and the needs of underserved communities. Even with the expansion of coverage through the Affordable Care Act, access to health care is only one component of improving health outcomes. Investing in upstream solutions that affect the social determinants of health, such as transportation, affordable housing, and workforce development, has been proven to have a greater impact on health. SB 346 will implement clear definitions of community benefit and give OSHPD more oversight into each hospital's activities. Furthermore, this bill represents a meaningful step towards addressing deeply rooted health barriers by closely integrating community input. As a health advocate myself, holding nonprofit hospitals accountable will lead to positive results for people that I've directly worked with. Investing in these upstream solutions can go a long way for folks in Oakland, where there's a shortage of affordable housing, or in Fresno, where community gardens have helped immigrant populations take ownership of their community, and in LA, where workforce trainings can help formerly incarcerated individuals get a sustainable job. Ultimately, these values of transparency, accountability, and community engagement are not only reasonable, but also beneficial for low-income and communities of color in most need. For these reasons, I respectfully request that you vote aye on Senate Bill 346.
Thank you. The remainder of the individuals, the proponents, if you can just state your name and position, please. We have some up here. We have some up here first.
Mr. Chair, members, Dwight Seum on behalf of Health Access California. We want to thank the author and the committee for amendments, and we will continue to work with the author on polishing the bill up further. Thank you.
Carrie Sanders with the California Pan-Ethnic Health Network, and we are supportive of men. We want to thank the author for his leadership on this issue and the co-sponsors for working closely with us to make this bill a reality. Thank you.
Noé Paramo, representing California Rural Legal Assistance Foundation, a proud co-sponsor of the bill in support. And I would also like to acknowledge that Sierra Leone Foundation is a grateful grant recipient of the Kaiser Foundation. Thank you.
Libby Sanchez on behalf of laborers local 777 and 792 in strong support of this measure.
Elizabeth Landsberg with the Western Center on Law and Poverty in support of the strong transparency provisions.
Sarah Flox, California Labor Federation in strong support.
Kathy Dennis, registered nurse, Dignity Health System in support.
Elizabeth Pataki, retired nurse in strong support.
Noelle Meredith Deegan, registered nurse, St. Vincent's Medical Center in Los Angeles, support.
Lady Manaug, Southern California Hospital, registered nurse, I support.
Lorna Lentejas, registered nurse, Southern California Hospital of Culver City, in support.
Marsha Martinez, registered nurse of Southern California Hospital, Culver City, I support.
Annabel Arroyo, registered nurse, Southern California Hospitals of Culver City, in support.
Violet Mayers, registered nurse, Southern California Hospital at Culver City, in support.
Alice Park, registered nurse in Southern California Hospital, Culver City. I support. Thank you.
Meg Hirigaramachi, Providence, St. John, Santa Monica. I strongly support.
Rosario Hernandez, San Gabriel Valley Medical Center. I support.
Mary Sanchez, San Gabriel Valley Medical Center. I support.
Margaret Legg, registered nurse, St. Joseph Healthcare System, and I'm in strong support.
Tiffany Nichols, Sutter Roseville Medical Center, and I support this.
Yanira McPherson, Southern California Hospital, in strong support.
Sam Rubion, Southern California Hospital, and I strongly support.
Dr. Stephen Cullen, I'm from Memorial Cares Hospital, San Clemente campus, in support.
Carol Wilson, community activist, in support of this bill. I'm in an underserved community whose hospital is closing by Memorial Care. Please support this bill.
Thank you. Opposition?
Here they come.
If we can make some room up here for the opposition, please.
Good afternoon, Senator and members of the committee. Catherine Scott, representing the California Hospital Association. I, too, am going to defer my time, but quickly, just a couple of things. Just to correct a quick statement, the IRS shows that there's been $5 billion in community benefits provided. We just want to make sure that's understood by the committee, that we are unclear where the $1.4 billion, one of our systems has gone over that by themselves, that it is $5 billion provided in community benefit. Also, we want to quickly, I'll be quick, clarify that the federal government did finalize their regs based on the Affordable Care Act at the end of last year, and that was an exhaustive process. That Affordable Care Act based their process on California's successful system. So the feds have been working for the better part of a couple years with lots of national community stakeholders to finalize that process for the Form 990 so that we can be transparent across hospitals throughout California and throughout the nation, and includes guidelines around community benefits and the like. So I'm going to stop now so I don't take up any more time.
Hi, good afternoon. My name is Leslie Medine, and I am here today on behalf of On the Move, a Napa-based nonprofit, to express our opposition to SB 346. We have serious concerns about the damage this bill will cause to existing partnerships between hospitals and community benefit organizations like ours. California's community benefit law is working. We, along with the populations we serve, are benefiting from successful collaborations between hospitals and the community, and as a result, together we are making real changes in the lives of real people in real time. Since 2003, On the Move has been dedicated to helping a diverse group of emerging leaders build exceptional programs based on their commitment, interests, and passions. We are proud to have partnered with Queen of the Valley on an innovative program called Parent University, which provides parents with the tools and knowledge necessary to become more involved in their children's education at school and in the community. This 5-year-old program serves over 1,200 parents each year. It is just one example of our partnership with local hospitals, and we know that it is making a positive impact in our community. What makes California's community benefit law so successful is the ability for hospitals to tailor programs for their specific community needs without the burden of vague, unrealistic, and costly mandates as proposed by SB 346. As you know, hospitals work collaboratively with communities and stakeholders to assess local health needs and tailor services and investments to address each community's specific needs. Queen of the Valley and other hospitals have embraced this collaboration, and together We are making great strides in building sustainable programs that provide important tools to address the needs of our community. These partnerships are vital to improving healthcare. SB 346 does nothing to strengthen those successful partnerships, and we fear it could lead to program cutbacks throughout California, impacting the diverse communities it is intending to benefit. We respectfully urge your opposition in order to preserve needed services like ours.
Good afternoon, Chair and committee members. I'm Shelley Schlenker with Dignity Health, representing our 33 California-based hospitals. SB 346 prohibits hospitals from reporting the actual cost of care and is in direct conflict with national efforts under the Affordable Care Act and the IRS to standardize community benefits. By mission and by law, Dignity Health treats all individuals who present needing medically necessary care regardless of ability to pay. Last year alone, Dignity Hospitals provided $176 million in traditional charity care under the federal definition, and a total of $1.97 billion in community benefit, including the shortfall of government-funded programs such as Medi-Cal. In addition to providing free or reduced cost care to needy Californians, Dignity Health is the largest private provider of Medi-Cal in the state, providing nearly 10% of all Medi-Cal services. To put this in perspective, that is about 550,000 inpatient days and more than a million outpatient visits a year. Last year, even after the funds from the Hospital Quality Assurance Act or provider fee, we lost $712 million from cost, not charges, serving Medi-Cal patients. These are real costs incurred in providing care. Under SB 346, we believe the reportable amount we could count is around $380 million, approximately half. With much of the shortfall not counting, though it counts at the federal level, we would have to rethink the scope of services we provide. Provisions in SB 346 create a disincentive to treat some of the most complex Medi-Cal patients, such as babies in NICUs, high-risk deliveries, or trauma victims. SB 346 fails to recognize the full extent of cost to provide care for the poor and needy and vulnerable. Dignity Health is proud of its ability to work with local community stakeholders to manage the types of health needs required in each community. Programs communities tell us are valuable may be at risk if SB 346 becomes law. For example, we run numerous chronic disease prevention and management programs with proven effectiveness. These programs benefit all populations. If we had to target only vulnerable populations, our ability to continue would be in question. Our state is in desperate need of more physicians. We run several physician residency programs that would not be recognized as valuable services under 346. And that there are also many services like burn units, trauma centers, NICUs, that we operate at a loss for all populations because they are needed. The federal government counts these losses as community benefit because they are vital to all in the community and meet the intent of not-for-profit status determinations. For these reasons, we strongly oppose SB 346.
Thank you. We can just, just state your name and position, please.
Mr. Chairman and members, Nathan Mansky, representing the Alliance of Catholic Healthcare, in opposition to the bill. Thank you.
David Ford for Adventist Health and Loma Linda University Health in opposition to the bill.
Angelica Gonzalez on behalf of Kaiser Permanente in opposition.
Tom Bone on behalf of Sutter Health in opposition.
Les Shepard representing Stanford Healthcare in opposition.
Anyone else in opposition? Comments from the members? Any questions? Yes, Senator Mitchell.
Thank you, Mr. Chair. A couple quick questions, Senator Wieckowski. Is the crux of the issue or your concern that the organizations are inappropriately counting some activities as community benefit, or is it a broader concern around the general underreporting of appropriate activities as community benefit?
Well, I think it's the inconsistency. It's the inconsistency. It's how they may be counting it. It's everybody, it's their CFO who's determining what the value is. You know, this bill doesn't, you're not setting the limit. All we're doing is we're having OSHPD set the limits of what is going to, how we're going to do the accounting of whatever the activity is, whatever the activity is of the community, the benefit. I think, does that answer it?
Yes, I guess. And could you respond to the witness from Dignity Health and her claim about, you know, their Medi-Cal losses and how they would be harmed? I mean, because we're all clear that the Medi-Cal reimbursement is nowhere near true cost reimbursement for services.
Right.
So could you respond to that claim?
Well, we amended the bill at least to bring it up that you can help, you can take the loss up to the Medi-Cal. You know, if it's the climate that we're in, nonprofit hospitals, profit hospitals, regular doctors, obstetricians, everybody that takes Medi-Cal is losing money. So they're no worse off. The bill, I'm hoping to at least allow them to count that shortfall that they have with the Medi-Cal. You know, that's the amendment.
Through the chair.
It's up through 125% of Medicare, so that they can take some of the losses up to.
Right. It's not everything. I'm not professing that it's everything, but it's an improvement of how the calculation. And again, it's OSHPD that's going to be ultimately setting these standardization.
Thank you.
Any other questions from the members? Seeing no questions.
Can I respond to, okay.
There's no questions that have been asked. Was there a motion? I'll move the bill.
Thank you very much. You know, the California and this committee, in many instances, when we were looking at the Affordable Care Act, has provided much better benefits than the minimum that's required. This bill will set clear benchmarks for all nonprofits when they establishes, one of my witnesses says, accountability, transparency, and input from our vulnerable communities. And we're going through with our recent legislation, lots of definitions and some attention to these communities. And I would urge an aye vote and allow us to continue this discussion.
Thank you. And we have item number 9, SB 346, due pass to appropriations. Call the members, please.
Hernandez.
Aye.
Hernandez, aye. Nguyen. Hall. Mitchell. Mitchell, aye. Monning. Nielsen. Pan. Roth. Wolk.
Currently has 2. We have a lot of members absent. We're going to place that bill on call.
I'll be in my.
Thank you very much. Are you still chairing that committee?
Yeah.
You're going to get done like about midnight tonight. You know that, right?